Welcome once again to the STEER video series by Dr. Amdekar's team. I am Dr. Tushar Maniar, pediatrician from Andheri, and I'll be talking on how important it is to check for eye manifestation of systemic disease. Now, when we look at this particular issue, let us divide this into two different areas. First, and more importantly, let us look at eye manifestations which may point us towards a systemic disorder, or in other words, whenever you encounter a similar eye manifestation, look for systemic causes for the same. And the second part will be, which are the systemic conditions or diagnoses in which we need to check for eye manifestation, either to diagnose, confirm, classify, or monitor the progress of that particular disease. Let's begin with eye manifestation by dividing the eye into different parts. So say, for example, eyelids. If you see ptosis, we have to think about ruling out early myasthenia gravis because that could be the first feature. Similarly, a retraction of the eyelids or exophthalmos with eyelids which are pushed up would point towards hyperthyroidism or Graves' disease. Next, we look at conjunctiva. If there is xerosis, we all know different classification of WHO vitamin A deficiency, and the early xerosis would be helpful in taking appropriate vitamin A supplementation to prevent further complications. Similarly, if you see a flictin present, that would point towards as an allergic manifestation of tuberculosis elsewhere in the body. We all know the child with fever of unknown origin, especially infant who is cranky, if you see perilimbal sparing on conjunctiva, that will help us in diagnosing Kawasaki disease, where you will have a red eye without discharge. And of course, a child comes with fracture or even without a fracture and you see blue sclera, you will start thinking in terms of osteogenesis imperfecta. Next, we look at cornea, and we all know the telltale sign of Wilson presenting as KF ring. So if you see a brownish discoloration present on the cornea and there are neurosigns, you would think about neuro-Wilsons. Similarly, if you have cloudy cornea, that is a nebulous corneal infiltration, that would point us towards mucopolysaccharidosis. And finally, if you see abnormal shape of the cornea in terms of keratoconus, that could be one of the manifestations of connective tissue disorder like Ehlers-Danlos syndrome. Let's look at the iris. If you see brush-filled spots, which we don't see commonly in Indians, but we do see in fair-skinned individuals, and that would be a marker for Down syndrome. If you see coloboma of the iris or aniridia, then one would look for Wilms tumor or certain other genetic conditions. And we all know that leash nodules will prompt us to make a diagnosis of cafeole with presence of cafeole spots towards neurofibromatosis type 1. We look at pupils with more of a CNS window or CNS abnormalities being detected rather than the eye abnormalities itself. And starting from a raised ICP with coning, which could be picked up because of unequal pupils, you may see a meiosis with ptosis and small eye, and you would think of Horner syndrome, where there will be multiple systemic causes, right from any tumor in the neck or from something as far away as neuroblastoma. Now at that time, if you see Horners with heterochromia, meaning both the irises are of different color in a young child, you would think of congenital causes of Horner syndrome. Next, we look at poisonings, and we know that meiosis or mydriasis are very important part of any toxidromes. And rarely you have what we have always been taught but rarely seen are like Argyll-Roberts-Robinson pupil, which you see in conditions like syphilis. Let us look at lens next. And we know that subluxation of the lens in upward direction would make us think in terms of Marfan's or Marfanoid syndrome, and in downward direction, it would make us think of homocystinuria. We know that white reflex in newborn makes us think of an eye condition with eye manifestation in terms of retinoblastoma, but also remember that it is more common to see a cataract or a severe ROP with as a white reflex. And we know that cataract can be present in children with intrauterine infections like rubella, or can develop later on in inborn errors of metabolism like galactosemia. And we do see different types of sunflower cataract and other options in diseases like Wilson's disease. Next, we look at uveitis, and we pay special attention to red eye without discharge, especially which is painful. And that would make us think in terms of uveitis, which could be silent or manifest. And hence, to diagnose this is very useful to decide the problems of polyarticular JIA and many other rheumatic conditions to see for any impending complications. Optic disc gives us an idea about raised intracranial pressure in terms of papilledema, or in certain metabolic condition by seeing optic atrophy and pallor. Retina, of course, has many findings which has systemic representation. Let us look at cherry red spot, where we know that retina gets the substance accumulation and the macula remains red, and that's why it looks like a cherry red spot, which is present in storage conditions like Tay-Sachs, Sandoff's, and some other. Occasionally, you will have retinitis pigmentosa as a diagnosis. Also, in shaken baby syndrome, you can get hemorrhages which can be noticed on retinal examination, which will point us towards non-accidental injuries. Also, we know that hypertensive and diabetic changes are reflected in chronic conditions on retina. Not only eye structure, but even eye movements help us in pointing towards a systemic condition. So if there is a presence of squint, which is recently developed, and it's only a paralytic squint on one side, you would think of false localizing sign as raised intracranial pressure for sixth nerve palsy. You may have Bell's palsy, which will show as a lower motor neuron seventh nerve, and so on. There are various conditions of cerebellum and vestibular system which presents as nystagmus. And we all know that hydrocephalus comes with sun-setting sign where there is an upward gaze palsy. So friends, here what we have covered till now are the eye manifestations which point toward a systemic condition. Let us look at it from another point of view, wherein you have systemic condition in which you have to pay special attention to eye changes. Let us look at rheumatological condition. We already spoke of Kawasaki disease, where a red eye with no discharge and perilimbal swelling sparing helps us in diagnosing Kawasaki. In polyarticular JIA, you have uveitis. When present, it will tell us that this is going to be an aggressive disease, and hence we would like to start a different set of treatment than the standard program. There are many other rheumatological conditions in which eye becomes not only a pointer but also important condition to monitor to see the response of your treatment. When we look at infections, rubella comes to mind first as an intrauterine infection which can present as cataract. But there are other conditions which are important, like infective endocarditis, which can be having small infective foci in the eye, which you can visualize. You can also have toxoplasma and tuberculosis rarely showing on the retina and on other parts of the eyes. Important to remember to check for eye when you have a diagnosis of NCC, because here your treatment will be different. If there are NCCs present in the eye, albendazole is contraindicated and only steroid with wait and watch therapy is advised. There are many metabolic conditions like we mentioned which present with cherry red spots and with cataract, but also there are conditions like immunodeficiency in which albinism becomes a marker for certain group of disorders where primary immunodeficiency is associated with them. In the CNS diseases, you can have pupillary changes, you can have extraocular movements which are paralyzed and affected, which could be in the form of a third nerve palsy, a sixth nerve palsy, it could be a seventh nerve Bell's with palsy with a disease. Finally, you can have only papillary edema and headache with no other neurological signs, which may point towards an idiopathic intracranial hypertension. So friends, to conclude, let us remember that eye is a window to many conditions, including systemic diseases. And whenever we have an eye abnormality, it is prudent to give a thought, pause and give a thought if we are dealing with any systemic conditions. Two simple examples we have already told you. If there is uveitis present with polyarticular GIA, one would not start first line treatment because it is known to be an aggressive disease, wherein you would start the next line of treatment in order to not delay as well as prevent the damage to the joint. And similarly, in neurocystic sarcoidosis, if there is eye affection, one would have to avoid giving albendazole even after giving steroids and treat only with steroids. So friends, we stop here, and this is to sensitize you that eye manifestations do not belong only to eye, and that could be a very useful marker for us to look for other systemic diseases. Thank you for your patient hearing.